Hi everyone, how are you today? Today we are going to discuss about another question regarding MRCS based on eMRCS. We will discuss all the questions of eMRCS, Fawzia sheets and recalls. Do you know solving question is one of the best way to pass the MRCS exam? Here is the question. Let us start the question here. You reviewed a 42 years old woman 8 months following a renal transplant for focal segmental glomerulosclerosis. She is on a combination of tacrolimus, mycophenolate, and prednisolone. She has now presented with a 5-day history of feeling generally unwell with jaundice, fatigue, and arthalgia. On examination, she has jaundice, widespread lymphadenopathy, and hepatomegaly. What is your most likely diagnosis? Here we can see 42 years old woman, 8 months following transplant. That means transplantation was done 8 months ago, and she was suffering from focal segmental glomerulosclerosis. Now she is taking tacrolimus, mycophenolate, and prednisolone. That means he is taking immunosuppressive agents, and now she developed last 5 days generally annoyed with jaundice, fatigue, and arthalgia, widespread lymphadenopathy, and hepatomegaly. So these all are the feature of inflammation. So an inflammatory process or infection is going through in her body. So what is the most likely diagnosis? Here we can see the options are hepatitis C virus, Epstein-Barr virus, HIV, hepatitis B, and cytomegalovirus. So in case of here, uh, 2 or 3 clue is more important. First of all, it is 8 months after the renal transplant. Second one, he is taking immunosuppressive agent, and immunosuppressive agent, uh, they provoke some infection which is opportunistic infection. And the 8 months, this timing is very important because before 6 months and after 6 months there are difference in infection. And the other causes here such as jaundice, fatigue, arthalgia, widespread lymphadenopathy, and hepatomegaly. That means this is an infectious case. So let's discuss some of the point according to this. Here we can see some of the rejection. First of all, hyperacute, acute, and chronic rejection. Here, hyperacute rejection occur due to antibody against donor HLA type 1 antigen and rarely seen HLA missing. And hyperacute rejection usually occurs due to preformed antibody against a definitive antigen. And then acute graft failure and hyperacute rejection, it occurs during the operation table usually due to preform antibody after entering into the body, they start reaction, and immediately during the operation table hyperacute rejection occur. Then acute graft failure or acute rejection, it occurs less than 6 months. And chronic graft failure or chronic rejection, it occurs after 6 months. So here, acute rejection, it is usually due to mismatch HLA. We know that the in the HLS at least 13 or 14 segment present. So as mass as mismatch, it will the graft failure occur that mass. Other causes include cytomegalovirus. So within the 6 months, we can see here there is an infectious agent which is cytomegalovirus infection, which causes acute graft failure that is less than 6 months. And in case of acute graft failure, usually by giving a steroid, it is possible to slow down the disease process. If resistance of the steroid, then monoclonal antibody can be given. Then the last one, which is chronic rejection or chronic graft failure, it occurs after the 6 month, and it occurs due to chronic allograft nephropathy, ureteric obstruction, and recurrence of original renal disease such as mesengiocapillary glomerulonephrosis, IgA nephropathy, focal segmental glomerulosclerosis. So here are the graft rejection and their time. In case of hyperacute rejection, it occurs during the operation table, and acute rejection it occurs within 6 months, and chronic rejection it occurs after the 6 months. So hyperacute it occurs immediately during the operation table or sometime within the operation. Then acute rejection, one of the infectious cause is very important, that is cytomegalovirus. And the third one, chronic graft rejection, they are occurred due to allograft nephropathy, ureteric obstruction. These two causes are most important for chronic graft rejection. So here, post transplant complication, we can see cytomegalovirus. Cytomegalovirus, it occurs or it causes infection within the first 4 to 6 months of the transplantation. On the other hand, we can see Epstein-Barr virus. It post-transplant lymphoproliferative disorder. It occurs usually after 6 months of transplantation. So these two term is very important. One is cytomegalo, another is Epstein-Barr virus. Cytomegalovirus, it causes infection before 6 months, and Epstein-Barr virus, they causes infection after 6 months. So this timing is very important. This is less than 6 months, and Epstein-Barr virus, it is more than 6 months. We can see another here is alphabetically. C is number 3 and E is number 5. So less time C and more time E5. So here we can see here uh, the women 8 months after the renal transplant. 8 months, that means it is more than 6 months. So our final answer is Epstein-Barr virus. We can see other options such as hepatitis C, HIV, hepatitis B, and cytomegalovirus. Cytomegalovirus, we saw there, it occurs before the 6 month, and hepatitis C and hepatitis B, they usually transfer by the blood and sexual intercourse and other blood product. Then we can see HIV usually don't causes disease itself. HIV usually causes the it decreases the immunity of the body, and the other opportunistic infection occurs. So in this case, HIV not possible. And other cause, hepatitis B, hepatitis C, they usually appears more early, and their manifestation are different from here. The manifestation such as petechialgia and other uh, presentation, which is not similar with the hepatitis B virus and hepatitis C virus. Thank you.